May I call upon the panelists, Dr. P.L. Alagammai, Professor of Gastroenterology, Meenakshi Mission Hospital, Madurai, Dr. Thirumoorthi, Professor of Gastroenterology, Adyar Cancer Center, Chennai. From the radiology point, Dr. Kirthi Sathyakumar, Consultant Radiologist from SRM Hospital, Chennai, Dr. Aparna J, Associate Professor, Hepatopancreatic Biliary Surgery, CMC Vellore, and Dr. Thomas Alex, Associate Professor, Department of Clinical Pathology, Christian Medical College Vellore. May I call upon the moderator, Dr. Ravish Sanghi Raju, Professor, Department of Hepatopancreatic Biliary Surgery, CMC Vellore.
Good afternoon. About half an hour ago, while coming to this hall, I passed the lunch hall. And I thought, should I have my lunch and then come, But then I thought it's not fair that you'd be hungry and I'd be full. And so just like you, I'm famished too. So we will try and finish this in a reasonable amount of time. Okay. So this is our patient. She is now 55, but she first came to us 6 years ago. She underwent imaging for another problem and was incidentally found to have chronic pancreatitis. She had endocrine and exocrine insufficiency at that time, mild abdominal pain, and never seen again subsequently. She then came back to us a few months ago with upper abdominal pain, a little more significant this time. But soon after she started having pain, she developed jaundice. And some weight loss. She was not sure how much weight she lost, but she definitely lost some appetite. On examination, she was a thick lady, a thin-built lady with a palpable gallbladder. So, Dr. Alagammai,
Hi.
what are your thoughts? What's going through your mind at this stage?
Yeah, here we have a patient who's a known case of chronic pancreatitis, and she was pain-free for such a long time, and now she has come with new onset pain. It's a red flag. So we should think of malignancy. CA pancreas comes into my mind first, considering new onset pain and some weight loss, and particularly jaundice, of course. So these are all red flag signs. However, we would consider differentials like an intrarectal fibrosis, and head inflammation causing obstruction of the CBD, or a stone which is impacting and causing obstruction of the CBD, or a pseudocyst compressing. These are all differentials, but considering the red flags of new onset pain and jaundice, I'd first go with the possibility of CA pancreas in the head.
Okay, so that's important because, okay. Sorry. So, what would you do for this patient? What next?
Yeah, baseline investigations will definitely get, because she's jaundice, we'll get an LFT first, we'll get a routine basic things, and we'll also ask for a tumor marker, CA19-9, and of course, cross-sectional imaging, and we'll go for CCT.
Fine. So I just put only the investigations of interest here. So patient is anemic. Cholesterol levels are extremely high. Like all of you, I thought whether the cholesterol and the triglyceride levels had been changed, but no, these values are correct. CA19-9 is mildly elevated. And the person definitely has some features of obstructive jaundice.
So definitely we have biliary obstruction. LFT is absolutely obstructive pattern. HB is low. Maybe still we have the first differential of malignancy. If it is infiltrating duodenum, there can be nuchal blood loss and HB is low. Or if it is extending to the periampullary, then HB is low because of unnoticed or nuchal blood loss. I am not able to fit cholesterol and triglyceride here. CA19-9 is little elevated, not in the range that I expected it to be in thousands. But it's still 10-20% of the patient can have a normal or a very low normal CA19-9 despite having malignancy. So I will still vote for CA pancreas, particularly in the presence of anemia and this much high bilirubin of more than 10.
So in your mind, you're thinking of malignancy, but you're still not able to rule out a benign problem. Is that correct?
I'm not.
Your first diagnosis, your first possibility is a malignant transformation.
I vote for CA pancreas, which is causing biliary obstruction.
So you said you wanted to do some radiological cross-sectional imaging.
Yeah.
So we'll ask Dr. Kirthi what she made, what she understood, or what the radiological investigation shows here.
I'm just going back to 2019. The patient had a CT at that time too. And what we see here is that the pancreas is completely atrophic. The main pancreatic duct is dilated and there are large chunky calcifications within the duct, also in the neck head region. Here we can see at that point in 2019, CBD is normal caliber, smooth tapering. There is no IHBRD. And here again we can clearly see the chunky coarse calcifications, no mass. So that time it was a classic chronic calcific pancreatitis with no other complications. So moving forward, 2025 patient has come back with a strong clinical suspicion of malignancy. So let's see what we find now. So these are contrast enhanced CT of the abdomen, and we can see now the patient has developed IHBRD, which is mild or almost moderate, was not there in the previous study. So we want to look for the cause for IHBRD, where is the obstruction. So I'm going down. This here is the dilated CBD. Then as we follow the CBD, we can see that there is an abrupt cutoff of the CBD at the level of pancreatic head. Also, the background pancreas is all atrophic with similar ductal parenchymal calcification. So there's a background chronic calcific pancreatitis, there's IHBRD and abrupt cutoff of the CBD at the level of pancreatic head. Another finding I want to impress upon is that the gallbladder is markedly dilated, and in fact it is quite dilated. We don't see this often in all patients. So generally what we do here is a combination of MR and CT called MRCT, where MRCP is done along with the CT images. So this is the MRI. Again, we can clearly see the moderate amount of IHBRD, which is significant. Then this is the dilated CBD. This is the dilated gallbladder. So the pancreas is atrophic, MPD dilated. So if you look carefully, the bile duct has abruptly cut off at this point, but there's no definite lesion. We're not really seeing any lesion. Okay. Now this is a video I have made. So basically, we do diffusion weighted images as a problem solving tool. So this is the T2 here. This is the diffusion image and this is the ADC map. So I'll just play this video. Okay, so we'll start looking at the T2 images. We're looking at the IHBRD now. I'll take you through the scan. So this is the IHBRD. So again, the dilated CBD, which the arrow is pointing to. And these are some portal lymphadenopathy. CBD is dilated here. And then as we follow, it's suddenly getting cut off. Okay, at this point there's cutoff. No obvious lesion on T2, but if you look carefully, there seems to be some diffusion restriction. So that was one suspicious finding on MRCP, which was not seen in other images. So this is just a summary of all our findings. There is significant IHBRD, this is the dilated cystic duct, and CBD with abrupt cutoff. It is not a tapered narrowing. And there is chronic calcific pancreatitis, no obvious mass on the CT, but on diffusion there is some suspicious restricted diffusion and the gallbladder is also hugely distended. So given these findings, what are our differentials? So number one, can it be an inflammatory or a benign stricture related to chronic pancreatitis, or are we considering a malignant stricture due to pancreatic ductal adenocarcinoma? So these two are our main contenders. But if in a similar picture, other things you may consider would be cholangiocarcinoma, autoimmune pancreatitis, ampullary carcinoma, not really in this case. So these two are our main differentials. So why is it challenging for us? Because there is background chronic pancreatitis, we may get confused. And sometimes atypical carcinoma can be iso-attenuating. That is, it looks just like the pancreas and we cannot make out on contrast imaging. And of course, there may be overlap between inflammatory and malignant strictures. And this is when, like in this particular case, the secondary signs are more reliable. So coming back to our case, summary of all the findings: chronic calcific pancreatitis, IHPRD and dilated CBD. And note here, the important point is that it is an abrupt cutoff of the CBD. It is not a smooth narrowing. So this is a secondary feature. Then is there a mass? Not very sure, but there was some diffusion restriction, so that is suspicious. And over-distended gallbladder is another, again, a secondary or an indirect finding. So given all these, I would definitely say that we cannot rule out a malignancy, particularly when there is such a high clinical suspicion, and we must consider the possibility of a malignant stricture, and I would suggest further evaluation with US and FNAC if possible.
So we now have this patient who's jaundiced, who's had chronic pancreatitis, there's no mass. In India, we talk about the head mass, and we worry about malignancy in the background of a head mass, but this patient has no head mass, a very distended gallbladder, but any patient with any obstructive jaundice can have gallbladder. So Dr. Thirumoorthi, if this patient came to you, would you be worried or not worried?
Definitely, this patient with the history-wise clinical findings and imaging, everything is more in favor of malignant stricture. Some malignant transformation has occurred in the pancreas. But the odd points are there is no mass lesion could be picked up in pancreas, either in the CT or in the MRI. That is one thing. Then the bilirubin is relatively high, it is 15 milligram. And relatively, I think the nutritional status is appears poor in this case. So for this, most probably it is a malignant etiology. Before doing that, we have to first establish what is the nature of lesion, what is the histological diagnosis. We should get that. Second one, to improve the nutritional status, we have to do some kind of endoscopic therapy. So for finding out the nature of the disease, we have to go for, in this case, since there is no obvious mass lesion in the CT or MRI, we have to go for a US as well as ERCP both together. Of which I will prefer to go for ERCP and doing for brush cytology or cholangioscopic biopsy, I will prefer. Why? Because the patient is having atrophic pancreas with a large intraductal calculi. Even though if there is some mass lesion is there or thickening is there, US will be, I think because of calcification, it will be little bit less sensitive. You may not able to take, even in the presence of mass with the calcifications. If you go with the US, because of calcification, finding a lesion will be difficult. But still, in this case, first I would suggest we will go for a ERCP and do a brush cytology. If required, we will do a cholangioscopic biopsy from the narrowing of the distal CBD. And of course, we will do the US. Sometimes we may find a small mass close to the distal CBD. We can access and we can take a US guided FNB that will guide us what is the nature of disease. And also suppose this patient is a candidate for surgery. Obviously is having abrupt cutoff, most likely we are suspecting malignant stricture, but maybe this patient will be requiring surgical procedure. So before deciding the type of surgical procedure, so we have to have some kind of biliary drainage. Second thing, suppose even if you think it is a malignant stricture, and we have to plan the type operability, whether it is upfront operable or borderline operable or inoperable. If it is upfront operable, no problem. So suppose if it is a borderline operable or inoperable and the tissue diagnosis comes as a malignancy, patient will be requiring some kind of neoadjuvant therapy. During that time, we have to have we have to decompress the biliary system. So for which, when we are doing ERCP and breast cytology, always will place a stent for decompress the biliary systems.
Are questions allowed? Here, questions allowed?
Sure, sir. I mean, want to do it at the end or would you do it now? Sure, please go ahead. I think that makes it more interesting.
No. See, for all practical purpose, any stricture towards the head region, EOS is a good modality for evaluation. So in this case, though I agree there is no obvious mass, EUS can pick up lesions. Not, I say that may be a challenge because of the headstones, but still I think it's good to look at EUS and see what's happening there.
So the primary issue here was or maybe I could just ask, but Aparna, what are the issues here?
Was EUS done? EUS FNB done for this case or not?
We'll come to that. The patient first came to a surgeon. So, unlike the usual patient. So, what according to you, what are the issues here?
This is a patient in the background of chronic pancreatitis, like ma'am highlighted with many of the red flags. Definitely the bilirubin level, by basic standards itself, higher than 10, very likely to be a malignant cause. We have the publication from Stanley where they use this bilirubin level of 5.8 in the background of chronic pancreatitis, which makes a malignant mass more likely. Jaundice is the biggest concern here in somebody who's been known to have chronic pancreatitis. The other problem remains that all of the other investigations that we just discussed, the yield of it is going to be somewhere between 60 to 70%, let's say a brush cytology. And if there's a negative report on that, it leaves us with no better option. We're still in the same position where malignancy still remains the strongest suspicion. So if this patient came to me first, I would probably not pursue any of these interventions or diagnostic modalities to prove malignancy. For all practical purposes, this would be a malignancy in the background of chronic pancreatitis. I would agree with Dr. Kirthi. The abrupt cutoff of the duct is a very, very strong suspicion for malignancy for me. The level at which the duct is cut off extremely high, which is very typical in carcinoma pancreas. And otherwise, to answer Dr. Thirumoorthi's question, the lesion definitely looks resectable based on the images that we've seen so far. So don't see a reason for biliary drainage either. So would definitely plan a resection.
So to answer your question, sir, EUS and FNA cost 10% of the Whipple cost in our institution. Endoscopic ERCP and biliary stenting also cost an additional 10%. So endoscopy in the presence of multiple large chunky stones in the head with no real mass on 2 imaging modalities was what I presume was what prevented us, or the reason we didn't do that. But coming back to Dr. Aparna, will you tell us, so you thought, okay, maybe I would operate straight. So you decided to operate straight. What did you find during the operation?
So I was part of this operation. So one thing in chronic pancreatitis, where generally we think tunneling might be difficult to get behind the pancreas because of long-standing inflammation, it wasn't so bad. But after transecting the pancreas as a routine, which we actually do, sending frozen section from the cut margin, we encountered positive duct margin in the first frozen section, and then we had to revise. The difficulty we encountered here while revising was that part of the pancreas actually was quite adherent to the splenic vein. Our suspicion for an extensive malignancy actually started at that point, where the planes with the splenic vein really seemed quite lost. So we revised the margin again. A second margin again came out to be positive for malignancy. And beyond that, we were not prepared for a total pancreatectomy, so we decided to stop at that point. We had already transected almost at the level of the splenic artery, and we had decided that's the amount of transection that we're going to do, and we stopped at that point. The final biopsy again came out to be malignancy. But in all of this, still we did not encounter a mass all through our operation. Even when we physically felt, we actually did not encounter a mass.
So a person with jaundice, no mass, low tumor markers, the surgeon decided to operate straight away. Diagnosis of a mass was confirmed, but first margin, second margin, and finally the third margin, all 3 margins were positive.
So I have some basic question. In the background of chronic calcific pancreatitis, more or less it is a malignant stricture. How will you decide the operability? So? as compared to clear-cut pancreas and head of pancreas mass.
Operability is primarily based on the vessel involvement, right?
Like in this case, like your surgeon has mentioned, there is a lot of fibrosis and splenic artery. We are not able to proceed. So, can we predict all these things beforehand? So, in that case, that is what the role of endo ultrasound, the drainage. If it is borderline operable, we can go for a neoadjuvant therapy, then followed by surgery. Then that will be the surgical outcome. May be good. That's what my opinion is.
Thank you. Dr. Thomas, would you like to comment on the path findings?
Right. So as the strong suspicion was malignancy, this was the Whipple specimen that we received, and this is the actual. So grossly, the picture was like it was a very ill-defined sort of firm mass around 3 centimeter, and the background pancreas looked very atrophic. And this is the tissue from the background pancreas. As you can see, a lot of fat, so a lot of atrophic pancreatitis in the background. And this was the picture from the dilated duct, one of the areas. And as you can see, there are a lot of tubular structures here, and that is actually the invasive adenocarcinoma coming out from this dilated duct. So we extensively sampled the tumor, looking at if there was any precursor lesions in the background. So some of the areas did look like there was flat high-grade dysplasia, but there was one of the sections that had this small, what do you say, call it papillary sort of growth in one of the duct sections. It could be a possible IPMN, but again, this was the only section that was available. Most of the areas of the dilated duct were actually ulcerated, and we couldn't make out the overlying lining. Most of it was just gone off, sloughed off, and we had the invasive adenocarcinoma. But there was just one of the sections which had a small papillae. Could be a possible IPMN in the background, but yeah. So the case was actually a moderately differential adenocarcinoma with a PT2 TNM stage, no LVIs, no nodes present.
So Dr. Aparna, what now?
So another thing which was quite shocking in this patient was for that amount of disease, no nodes positive. So that's again something that did not fit with how we expect carcinoma pancreas to behave. In my conversations with Dr. Thomas during this patient also, one of the strongest suspicions was if it was an IPMN which was involving the entire length of the pancreas, which might explain why we are not actually seeing a mass, and how after 3 different levels of transection we still continue to get a positive margin. So that was one of the suspicions, and we probably do not pick up the IPMN because the duct is probably packed with stones already. So that was one of the thoughts at the end of the pathology report as well.
So what happened to this patient?
So she had a little bit of a difficult recovery post-op, but she made it out okay. Our plan has been to definitely treat this as R1 disease, given that we have a duct margin which is positive. So we've decided to give her local radiation therapy along with capecitabine to start off with, and keep her on a close follow-up. Now that the thought that IPMN is also there, we are more keen to follow up. She could develop concomitant cancers in the remnant pancreas as well, apart from a local recurrence. So she will need very intense close follow-up to make sure she doesn't develop malignancy again.
In our department, we have a policy that if one surgeon sees a patient, before the patient goes to theatre, that patient is seen by another senior surgeon. And somebody discussed this patient with me. I will be honest, I did not think this patient had cancer. I thought we would end up with a benign problem. But because 2 other surgeons in my department, senior surgeons, were very, very sure this was cancer, I said, okay, we will go ahead with this operation, and came out to be malignant. Now, the few things which were different. To be honest, biliary stricture, an abrupt cutoff of biliary stricture, I have seen a lot of benign patients with abrupt, so it need not necessarily, chronic pancreatitis need not necessarily have a tapered end. Gallbladder is palpable in all distal obstructions, so that is not a great sign. Tumor marker was negative, despite the patient having jaundice. Jaundice without any tumor markers go up, tumor marker again, all these were bad. But we know that, at least in the initial phases, the jaundice levels don't rise so much in benign disease. Also, jaundice levels fluctuate. So this person had just one just one level, a very aggressive, very rapid rise of jaundice, and a jaundice which progressed even beyond this by the time they had the operation. So maybe to me that is the biggest red flag of all the red flags. And so now coming back to this audience, would you think this patient had malignancy if you had seen it? Would you have recommended radical resection operation? And would you have tried doing an EUS? EUS where the stones in the head are very large. A pancreatic cancer, I'm not sure, maybe you guys know better than me, a pancreatic cancer compressing the biliary system, I'm not sure how good brush cytology is in that. We know brush cytology is good for cholangiocarcinomas, but for pancreatic cancer, would your brush cytology have picked up? I'm not very sure. So what are your thoughts? Maybe we just end just the last question of the conference.
I would have definitely done a EUS if the patient was.
So, brush cytology alone or EUS FNA alone, the yield is less. It is around 40%. When you combine both modalities, it is almost 80 to 90% we will get. Over and above, even we can go for cholangioscopy guided. We will not apply one modality because each one modality has a very low specific, low yield of for that malignancy. So we can apply multiple modalities in a single setting like cholangioscopic biopsy, ERCP and brush cytology, and EUS if you are finding any mass lesion or CBD thicknesses, suppose if it is more than 3 millimeter, in that case we can go for FN or FNB, so that yield will be higher. So that we can we can predict and prepare the patient for any treatment like surgical or any kind of treatment.
Thank you. What about the audience? Benign, malignant, not sure, EUS, FNA? Say something. Supposed to have learned something. No? Okay, a lot of disbelief. Thank you. So thank you for patiently waiting, and I thank all the panelists for all their contributions.
Thank you.